Hey everybody, this is Dr. Ben Pearl with FitFootU, and today I am honored to have a scholar and a practicing podiatrist. How many years, Dr. Jacobs? Dr.
Well, I graduated in 1973.
Yeah, so he's been around as long as anybody really, but he's, as I like to say, still keenly sharp, and his wit is as sharp as a scalpel. In fact, I kind of look at him as sort of the Mark Twain of podiatry. He's kind of seen it all, and he hails from St. Louis, I guess, right? Is that where you were born and raised, or?
No, actually, I'm a native Philadelphian.
Okay.
And a dedicated Philadelphia Eagles fan.
All right. Well, we have that corrected. But you've been practicing for some time. How many years in the St. Louis area?
I got here in 1980.
Okay.
So it's been 44 years here.
No, I was introduced to you by the late, great Debbie Tuccia, and she had a great Virginia Beach meeting that she was the scientific chairman of, and just a loss as a person and to the profession. But she always got great speakers. You were one of them. And right from the get-go, I could sense that you, like Gerard, you were different in that you really brought a lot of broad medical knowledge base to the common podiatry practice about things we can do to expand our range of what we do, but still staying in our lane. So maybe you could speak to some of the things that you're excited about, because I know you're passionate.
I think in recent years, my passion, although it's not exclusive to this area, has been on trying to motivate the medical aspects of our profession. I feel that there's been a failure in terms of the progress of primary care medicine in podiatry. We've seen tremendous growth on the surgical side, for example, the American College of Foot and Ankle Surgeons. Many of our seminars have become surgery dominated, and I feel we've sort of left behind many of the medical aspects. So if you attend a typical podiatry seminar, for example, unless a corporation is sponsoring a particular product, for example, lowering of uric acid, for example, you don't get good lectures in rheumatology, or even dermatology tends to be oftentimes focused around procedures such as biopsy or epidermal nerve fiber density testing. We don't see much discussion at all in the areas of neurology, for example, and many of the things that we see every day in our practices, and particularly given the growth of diabetes. I mean, Ben, I remember when I started practice in 1975, we hardly saw a diabetic patient. I remember being a student at PCPM in my third year in the clinic. I had my little short white coat on, and I went to my clinician and I said, I have a gentleman here, and he's here to have his toenails cut, and he's diabetic. And my clinician looked at me and he said, hurry up and get him out of here before something happens. And back then, as you know, it was verboten to even think about doing surgery on a diabetic patient. I mean, the suggestion that you would have corrected a hammer toe or a bunion in a diabetic patient was heresy. And we were taught that things like Charcot joints were rare. And now look what we do. We do Charcot recons on these patients. We do surgery to prevent ulcerations by correcting rigid deformities, and yet Medicare still pays you to do so-called at-risk foot care for fear that they'll nick themselves cutting their toenails. And yet we're slamming IM nails in these people and surrounding them with frames and doing things like that. But it's everyday podiatry that's really my passion, because too much of podiatry in the non-surgical realm, in my opinion, Ben, maybe you disagree and see it differently in Virginia, because Virginia's always been a little bit ahead of the curve because of the wonderful residency programs that have been available there. But I don't think it's representative of the entire country. But I think too often podiatry and diabetes means cutting toenails or callus work and selling shoes once a year. And that is not prevention of ulceration and prevention of amputation. To me, prevention of amputation is getting involved at a multifactorial level in terms of deformities, evaluation and treatment of neuropathy for improving quality of life, early detection of vascular disease, treatment of dermatologic disorders that affect the diabetic patient with increased frequency, fall prevention, because we know that diabetics have an increased risk of falls. And all of these things are important things to do. They lower risk and improve quality of life for our diabetic patients, and they increase income to your office. And I would argue that the majority of patients who come to your office for so-called at-risk foot care should probably have at least an office visit, a 99212 or a 99213, together with that visit, that you should be evaluating them and treating them for these multiple problems that are there. And I just don't think it happens. I think we come in, they get their toenails cut or their calluses trimmed, and then they're out the door. And the patient's going, well, doctor, my feet burn, or my feet are numb, or having balance issues, or something like that, and they're being totally ignored. And I think part of that is because we're not really emphasizing these things in our seminars. The only thing that really gets seminars focused in diabetes, in my opinion, is ulcer management. And that's because we have tremendous corporate input in sponsoring speakers to come to our meetings and push particular products that may or may not be helpful in resolving ulcers, Ben. You know, you walk around any wound care meeting, and they're enormous now, as you know, wound care is big business, and you see exhibit halls that overflow the facility. There are so many wound care products, and everyone's claiming 80%, 90% successful healing of ulcers, and yet diabetic ulcers remain difficult to heal. They remain a high rate of recidivism, and I almost want to say it must be malpractice not to heal a diabetic ulcer, because all these products claim 80-90% success, and yet in reality we know that's not true. But if you take away ulcer management and ulcer products, we don't teach that much in terms of, for example, neuropathy and practical management. And a lot of things can be done by the average podiatrist, for example, to take neuropathy as an example, to improve quality of life, frequently to stop the progression of the neuropathy. And we don't do these things because it's just true medicine, in my opinion, is not being emphasized enough in our meetings, because they're not corporate sponsored, unless there's a particular product that's being pushed to treat a say neuropathy, for example, or vascular disease. We're not that involved in vascular disease, other than sometimes making the diagnosis and referring them out to interventional cardiology or radiology or vascular surgeon or whoever you refer to. That's really my passion, Ben.
Let's tackle them one by one. You mentioned Charcot, and then we also know that diabetics, even if they don't have a full Charcot, are at risk for fracture just because of the neuropathic changes and the osteopenia that can result, or osteoporosis. What are some of the things that you feel comfortable as podiatrists that we should be doing to enhance the probability that if a Charcot goes on to surgery, that result, or in terms of a risk or healing of fractures with diabetics? What are some of the things you would suggest?
Well, first of all, Ben, the first thing is recognition. I still see patients who come in with advanced Charcot who were not diagnosed by a podiatrist. I understand it if a non-podiatrist misses this. I got it. I had a patient of mine that saw a pain management doctor recently with a fracture dislocation midfoot, needs a reduction, but I sent the patient back to pain management because they were under pain management, and the pain management doctor called me and said, well, this must be complex regional pain syndrome because the foot's swollen and red and it's warm. And he never heard of or knew anything about Charcot joints. So I could understand an MD not knowing this. but not a podiatrist, yet I still see it. So number one is recognition, being suspicious early on and working these patients up with x-rays or a bone scan. Number two is following the recommendations of the International Working Group. And if you suspect a Charcot, you immediately get them off the foot, you immediately immobilize them and non-weight bear them in a long leg device, preferably a cast or a long leg boot, but they're off it until proven otherwise. And you want to monitor their temperature, you want to monitor their radiographic and clinical progress. You're supposed to monitor their temperatures and wait till there's less than 2 degrees centigrade difference between the Charcot and the uninvolved side, unless they have a bilateral Charcot. And then, yes, there are things I think that are helpful to try to expedite resolution. Now, the things I tend to use are either calcitonin nasal spray, or I will use a bisphosphonate, either something like Fosamax, 70 milligrams once a week, or if I can get it approved, I will still infuse them with a bisphosphonate. Now, to be fair about this, the studies go both ways. The International Working Group on the Diabetic Foot does not recommend the use of bisphosphonates or calcitonin because they're not proven to work. But it's like a lot of therapies we utilize in our practices. Just because something is not proven doesn't mean it doesn't work, and it doesn't mean it's unnecessary. It just means that no one has taken the time to gather appropriate data to prove that it works. But all therapies that we use today start out at some point as unproven therapies. So, and we could point to a lot of things like that. So I think the biggest thing to me, number one, is early recognition. We're still missing them. Number two is a long leg device. Number three is getting them off it. Number four is proper monitoring. As far as surgery goes, I think I remember years ago, a very famous person, our profession, being upset that surgeons had claimed dominance over Charcot joints. We still don't have fixed paradigms for when we do surgery and when we don't. We have no data to show us the best way to fix a Charcot or stabilize a Charcot, whether it should be internal or external, whether it should be plantar, medial, dorsal. We just don't have that data. Everyone has their own way of approaching it. And we're not even clear as to exactly what Charcots should be operated on. When I started practice, there is no way you would have operated on an ankle hold stage 1 Charcot. They would have said you have to wait till it's stage 3 and then go back and sort of repair the damage. Now we have moved that back to doing surgery on active Charcots to at least try to stabilize them and keep them from collapsing. So we don't even have fixed ways. People tend to go the way that their residency director did things, if their residency directors were involved in that work, or they tend to go with the manner in which corporations tend to influence them to go. So Charcots are tough, and they're high-risk patients, as you know. I have one in the hospital now with a massive Charcot. He's going to be having his leg amputated tomorrow. He is your classic overweight diabetic, poorly controlled, chronic kidney disease, and developed a massive Charcot, a hemarthrosis, secondary Pseudomonas infection, and there's unfortunately no salvaging these patients. And as somebody who does a fair amount of med-mal work, I could tell you that Charcot joints and surgery for Charcot are not uncommonly the source of malpractice litigation. And some of the cases I've been involved in have been rather leading names in our profession who are up there professing, go ahead and do this and do that. And they may show you the successful case, but they're not showing you the ones that ended up with limb amputation or sepsis or near-death experiences or death. So these are dangerous patients in dangerous places. And, you know, it's kind of funny. You see this common argument right now in PM Magazine and other places about our podiatrists, real doctors, and is our education equivalent to an MD? Look at the patients that we are taking care of, that we're being trusted with. These are patients with complex medical issues. these diabetic patients just don't have neuropathy, and we're being charged to take care of these complicated medical patients. You know, the orthopod that I consulted to do the below-knee amputation on my patient being amputated tomorrow, he comes in, he sees all the comorbids, and he writes in the chart, well, this patient has a lot of stuff wrong, and have medicine fix it all up, and then I'll come back and take the leg off. He didn't pretend to know about, you know, hypertension or chronic kidney disease or fluid and electrolyte abnormalities in my patient, or the COPD the guy's got. He just said, hey, I'm here to do a job, fix everything up, and so I don't kill the guy, and then I'll come back and take the leg off. But we're getting stuck with these patients more and more. And I almost worry about podiatry being pigeonholed into the wound care diabetic scene and not getting anything else like major trauma.
So let's go back a moment on just some of the things you said about detection. How do you monitor temperature, pre-ulcerative Charcot changes in your office? Do you use strips? Do you use more sophisticated equipment?
I have a simple thermocouple that we use to measure, and you look for 2 degrees centigrade, 4 degrees Fahrenheit difference between the legs. If you have a bilateral Charcot, then you sort of go up the leg and do the best you can to try to figure out when they're calmed down. And you use the temperature, their clinical presentation, and their x-ray presentation, and you warn the patients that they can't have a recurrence, and if they do, they got to get right off it. And it's very frustrating for patients, as you know. You have a very famous podiatrist in your area in Virginia who recommends, for example, early Achilles tendon lengthenings or gastroc recessions to try to expedite resolution of these things. And I went through that for a while, and then again, there's people who say early stabilization. I think if you have a major dislocation and it's obvious to you that this deformity is more likely than not to be associated with an ulceration, and it's not going to be compatible with shoe wear, then I think you go in early and try to reduce it when it's earlier, easier to reduce, and stabilize them however you think is the best approach. I mean, I've gone back and forth between beams and external fixation and early on, but I think you have to do something once they're seriously collapsed, because it's not going to get better, it's just going to get worse.
Let's go back to another area that you outlined, which is diabetic neuropathy. And there's certainly a lot of crossover, and many of us have become versed in part through technology, in part through companies making things aware, but then in part, I guess, through just looking at the science and listening in lectures. What is, first of all, you did mention neural skin testing. What is the role there for that? We know that obviously there's clinical things that we do as a precursor, but where do you see that as a niche or versus overutilization?
Okay, Ben, first of all, if you look at people who have published and researched in this area, famous names like Bolton or Peter Dick, people like that. I mean, very famous people. Some of them are from your area, like Vinnick, for example. They have published this and said, you can diagnose diabetic neuropathy with 87% accuracy with no testing, just in your office, doing reflexes, vibratory, light touch, pinprick. That's it. That's all you really need 87% of the time. So that's number one. Where does epidermal nerve fiber density testing fit in? That's heavily marketed. And the rationale is most diabetic neuropathy starts as small fiber neuropathy, and small fiber neuropathy is not detected by standard nerve conduction studies. So that's large fiber. So they say you can't rely on nerve conduction studies because you could have small fiber. So go ahead and do the epidermal nerve fiber density test. Well, that's not consistent with what's published by the major leaders in neuropathy. And number two is it's not consistent with the policies of most insurance carriers. And they say, where does epidermal nerve fiber density testing fit in? It's a patient that has symptoms of neuropathy. they have a disease with which neuropathy is known to be associated, and they have negative electrodiagnostic studies, but you still feel there may be neuropathy. So you go ahead and you get an epidermal nerve fiber density test. So if it comes back small fiber neuropathy, fine, you've said now they've got it. Now what do you do with that information, Ben? You're a podiatrist, not a neurologist. Are you going to start working them up for an occult carcinoma? Are you going to work them up for sarcoidosis? Are you going to work them up for... No. So the most you get out of epidermal nerve fiber density testing is yes. They do have evidence of small fiber neuropathy. Now what do you do with that information? So that the insurance carriers are very clear universally about where that test belongs. Our experts that we rely on, who are neurologists and endocrinologists, tell us here is where that test belongs. But the people that push it are companies that market the test because it pays extremely well. That's the problem with that test. So in most instances, you do not need detailed testing. Where is it helpful? It might be helpful, although it's difficult. Many diabetics have a superimposed entrapment neuropathy, most commonly tarsal tunnel, less commonly superficial or deep perineal nerve or common perineal nerve. So sometimes you may have symptoms, say, just restricted to the plantar surface of the foot, and you're thinking, I wonder if they have a tarsal tunnel superimposed on their diabetic neuropathy, or maybe they have a history of spinal stenosis, and you're wondering, am I seeing a tarsal tunnel or diabetic neuropathy or spinal stenosis or some combination, so-called double crush syndrome? That's where some of these tests like nerve conduction studies fit in. But even there, they're difficult to diagnose because take tarsal tunnel, you're looking to see normal posterior tibial nerve conduction until you get to the tunnel, and then you want to see abnormalities distal to that. But if they have neuropathy or they have spinal stenosis, you're dealing with abnormalities in the baseline nerve above the tunnel to begin with. So you have to rely on your experience and clinical judgment. But there's another example of where we got led down a wrong tree, and everyone was thinking that you could cure diabetic neuropathy by doing nerve releases all over the foot and leg. And that's it. And that was condemned by the American Academy of Neurology. It was condemned by the American Diabetes Association, unless you have evidence of a focal nerve entrapment that requires release. And that's legitimate. But you don't do nerve releases for peripheral neuropathy without focal nerve entrapment. So my passion is more in treating the symptomatic neuropathy and treating asymptomatic neuropathy. I write for a lot of gabapentin and gabapentinoids like Lyrica. I use a lot of tricyclics and a lot of SNRIs, but I understand not all podiatrists are comfortable writing for these types of medicines. I got it. You could learn to do it, but a lot of people don't want that responsibility. But you've got a lot of good topical compounded medications out there now. You've got a lot of compounded collections of drugs like alpha lipoic acid and vitamin B complex and L-methylfolate and benfotiamine and a lot of these things, B12, a lot of our diabetic patients.
So you like the evidence that you've seen on things like the more bioavailable folate, et cetera, some of those?
Absolutely. And the data is there. And even people like Andy Bolton in the most recent article he wrote last year in the Diabetes Care that had a whole issue on diabetic neuropathy, even he has come around to that. Especially if I have a message for your listeners, Ben, take something like metformin. Most patients are started on metformin. Metformin interferes with intrinsic factor. No one argues that. It interferes with vitamin B absorption. No one argues that. The studies are there in multiple legitimate journals to show that patients who are on metformin get worse neuropathy. There's no argument about that. And the data is there to show that supplementation with L-methylfolate and methylcobalamin frequently, not always, but frequently reverse the neuropathic effects of the metformin. and stop the progression and sometimes even reverse the neuropathy symptoms. So that's been well established for a long time, Ben. And when I see a patient who's on metformin, I do my standard neurologic exam and I tell them, I'm going to put you on this, and here is the reason why. And most patients do that, and it's good for the patient, and it adds extra income to your office. And I don't know why podiatrists are not more involved in this than they are.
And so it's important also to educate the patient that if they're just getting a B12 shot from their primary care, if he's following the B12, that there's other things in terms of the availability of the subcomponents and auxiliary components that help with neuropathy.
Absolutely. Another example is vitamin D, that it's become clear is most of us think about bone health when we think about vitamin D, but it's been shown, particularly in minority patients, vitamin D deficiency is not an infrequent contributor to diabetic neuropathy. In Europe, they use a lot of alpha lipoic acid, which is a fatty acid. So here's an example of a drug or supplement, if you want to call it that, that any podiatrist can use. They don't have to be fearful of palpitations or any cholinergic side effects or neuropsychiatric. They don't have to worry like they would with, oh, I don't want to write for, pregabalin or amitriptyline. I got it. But why not use amitriptyline? In Europe, it's one of the first things they write for. You give them anywhere from 600 to 1,800 milligrams a day, and there's a good percentage of patients whose neuropathy symptoms improve or reverse just with that. Why wouldn't you use something like that? You're now treating their neuropathy in addition to providing their routine foot care. You're adding an office visit, so you're practicing medicine. You're potentially helping a certain percentage of patients, and you're making extra money legitimately. And I just don't understand why people wouldn't be involved doing that. Maybe you could explain it to me, Ben. And I argue the reason is we're not teaching it in our meetings. The only medicine we teach in podiatry meetings is when it's associated with some product where somebody's up there doing an infomercial and they're really not doing a lecture, that there's a hidden agenda behind it all. But beyond that, I don't think we teach a lot of medicine in our meetings.
Well, I think it's incumbent on all of us to keep reading, keep researching, see what the NIH has to say about different things, and as we do pick up things on different nutrients that we weren't aware of, as things become more talked about and more relevant. What's your feeling on some of these new things that our primary care colleagues are doing for diabetes and lipid lowering? With things like Ozempic, how do you think that's going to scale in, and where do you think our role is with being aware of that and what we can do to help our patients?
Well, here again, I think anything that benefits when we speak to our diabetic patients, it's kind of like speaking to a 340-pound heel pain patient. How do you not tell them that weight loss has got to be part of this? How could you not tell them that? We're going to just say, well, you've got a compensated forefoot valgus and this orthotic is going to do it. Of course not. So it's the same thing with diabetes. We want to encourage lifestyle change. We want to encourage them to diet change when they come in, and we ask them what their last A1C was, and it was down a little bit. We get excited with them and encourage them to continue on. So yeah, we need to learn about these medications. Some of them have an impact, as you know, in the perioperative period. Some of them have to be stopped for various periods of time. And of course, anything we do that's going to improve their diabetic state overall is going to improve their neuropathy, for example, because neuropathy, like most of what we see in the foot with diabetes, whether it's skin changes from glycosylated proteins or whatever, these are metabolic changes. And anything we could do to improve that metabolism and restore basic homeostasis is going to benefit our patients. The other thing is it makes you look like a doctor. If all you do is cut toenails on people and sell them shoes once a year, if that's all you do, Ben, then don't be upset when that patient comes to your office with a cast on because they broke their fifth metatarsal and they never thought to see you. They went to a real doctor because you set the tone by saying, here's what I do. I cut your toenails. I don't examine you. I don't pay attention when you're telling me about other related complaints or concerns. So you kind of set the standard of being a sort of a sophisticated toenail cutter that Medicare will pay for. So all of that's important, and it shows a knowledge of medicine. It shows some concern. And in today's world, I think the more you spend face to face with your patient discussing things, the more they will appreciate and respect you because they're not getting it in their primary care offices. They're seeing PAs, they're seeing nurse practitioners, and they're not even seeing the doctor half the time. Like you, I'm sure I've got many patients that have still never met their primary care doctor. They tell me, well, if I was ever really sick, I would see the doctor. Well, how would you know when you're seeing a 3-year educated PA and not a doctor?
We know that diabetics are notorious for compliance. What do you feel the role, and you've already sort of put out there that developing the more collateral relationship on all their other things for well-being is important. But what do you think the role of some of this home monitoring, different types of compliance reinforcement things? I have my own opinions, but I want to hear yours.
Well, there's two things I have to say. One is who's going to pay for it. That's number one. And here again, we have tremendous corporate influence. You hire someone that may or may not be respected or supposedly is respected, and they become a mouthpiece for your device, whatever it is. I mean, we've got people in our profession that are like Ed McMahon on the old Johnny Carson show. They sell you something every week. They've got a new product that's going to cure everybody and prevent ulcers. And number two, quite frankly, patients don't do it. And that's just a reality. It's like everything. It's like when you give them stretching programs. They start out and they're compliant at first, and then it fades away and it stops getting done. Because what these studies don't show is that long term, we do in fact reduce ulceration. We keep talking about the potential to reduce problems, and we have these short-term studies. And again, studies can be you can adjust endpoints and make anything sound reasonable. So cost is an issue, and because diabetes is going to bankrupt this country, it's just a massive problem, as you know. And now we're adding expensive home monitoring. And number two, patients are not going to keep up with it. It's just not going to happen.
They're not going to comply with ironically, the compliance type monitoring devices. I could definitely see that happen. I mean, we know how much, when you look at longitudinal studies, how many people drop out of the follow-ups for the study. Sometimes that's why there'll be endpoints at like 3 months because they couldn't get the patients to follow up at 6 months.
Exactly. I think the most powerful thing you can do, honestly, is what I've learned in my years is that first visit with the patient. That's the time to sit down, do a complete exam, show them, number one, you're a doctor, okay? Then you discuss with them their risk factors for ulceration. And you tell them, my job as a podiatrist is to lower your risk for limb loss or amputation or ulcers and so forth. I say, you're diabetic and you have certain risks for losing this leg. And my job is to help you to try to prevent that from happening. I can't promise we could prevent it, but here's the things that are wrong, and here's the things you need to go about doing. It could be something simple, like we know from work done right there in Virginia by Bill Grant, for example, who first identified the changes in the Achilles tendon in diabetic patients. So simply show them this is tight, you've got to stretch it, or if you need to, sell them a night splint, but putting them on a program and explaining why, getting them in devices to redistribute weight, talking to them about skin care and what they need to do to care for their skin, treating their neuropathy, particularly if it's asymptomatic, getting involved in accommodation for deformities, or even talking to them about preventive surgery. The time to do it is the first visit to show them that you do care. It's going to be up to you, and then reinforcing that for the next several visits. The last thing you get to is the toenails or the calluses. That's sort of an afterthought. And I think if you set the ground and let them know you are at risk, but if you don't do a neurologic exam, then they don't know they have neuropathy. And if they come in obviously with paresthesia, dysesthesia, that's one thing. But a lot of times I'll put that tuning fork on them, or do light touch with an Ipswich test, or do a 10-gram filament, or temperature perception. And then you show them they can't feel it on their foot, they can feel it in their hand. You're going to be the first person to make them realize that diabetes is affecting them, and they are getting neuropathy, and they don't want to lose their leg, and so they do need to cooperate. Or explaining to them how that tight calf muscle increases load. It takes a little bit of time, so you upcode that visit, because don't forget, as you know, you can now bill for time as well as your E&M, and so take the time to educate them and document it. I took, this is a level 3 or 4 first visit, because I took the time to educate them about these risk factors and then list them in your note. And then for every risk factor you identify, institute a program for that patient. So again, it makes you a better doctor. It lowers the risk for the patient, and you make more money doing it. I don't know what else you have to get more involved with our diabetic patients at the primary care level.
Now, we're in the home stretch here, so I want to just finish with a couple things. I listened to Dean's podcast with you that was fairly recent, and you mentioned how you like to sometimes de-escalate the tension, or in part bond with the patient by interjecting a little bit of humor, and you mentioned a biscuit anecdote. What other anecdotes or things that you do on a more general basis, or something specifically that you've done where you were able to use humor as a tool to help connect with patients?
I just think that in today's world, I think a good joke, a clean joke, that kind of thing, like saying, what did one cannibal say to the other when they ate a comedian? And the patient looks at you and you go, well, the one cannibal said, does that taste funny to you? I mean, it's just that kind of thing. See how you smiled? Just a little thing like that sort of helps out and makes you human, because, a lot of doctors sort of have this superior-esque attitude towards their patients. And I want them to know that we're humans. And I think podiatrists do that better than anybody. You talk to most reps, they'd rather call on a podiatrist any day than an MD colleague, because they're treated like pile of poop by the MDs. Podiatrists tend to be more receptive, and I think we tend to be closer to them than others. So I think it's helpful.
And I'll leave you with this final thought. Where do you see the future of our niches with podiatry going? People have asked me when I told them I was talking with you to get your sense of the big buy groups, the private equity groups that own some practices, and in that same breath, podiatric education and residency and the next wave. I mean, we could do a whole bit on that, but just in a nutshell, maybe comment a little bit on where you see the future trends.
I think the people that are doing the best, in my opinion, the way things are trending, are number one, joining an orthopedic group or a medical group. I think that should be the number one choice, absolutely. RX residents who've joined these hospitals or medical groups or orthopedic groups are doing wonderfully financially. They are sort of protected because the view's a little different than going into a private office. The perception is just different, and they're making good money, and they're treating good pathology. So I kind of like that. I think private practice in itself is going to be more difficult to manage, as you know. for any number of reasons. I think if you're in the right city, if you are in the right area, you probably can do quite well in private practice. But I think some of that is going to slowly disappear. But I think the podiatry future is solid. I tell the residents all the time, you are so lucky. You have diabetes increasing. You have a flood of immigrants that are coming from countries where the incidence of diabetes is even higher than it is here, and it's a slam dunk they haven't been treated there. You've got increased old people like me running around trying to pretend that they're athletes, whether they're doing something like pickleball or trying to whatever. And you've got aging. The aging population is, as you know, the largest segment in our country. So you've got aging, you've got diabetes, you've got sports, and you've got declining attendance at podiatry schools. And old guys like me are going to be leaving or dropping dead or whatever's going to happen. And so there's going to be less and less podiatrists available, and they're going to be filling a bigger and bigger role. So they've got it made. But my first choice, my first recommendation to anyone is if you could get into an orthopedic group or a medical group or work for a hospital, I think that's the way to go, honestly. And private practice has been great for entrepreneurial, smart people in the past, but that's going to slowly disappear as there's more and more consolidation. I mean, I look at St. Louis, we're a small town, and we're controlled basically by three major healthcare systems, and you're either in or you're out. And if you're not an in-person, the question becomes, how are you going to access patients? It's doable, but you've got to have the right mindset to do it. I've never been a business guy. I've always been a medicine guy, and I've been lucky that I've survived without being real smart as to how to market and how to do whatever. But in the future, I don't think that's going to be possible. So podiatry's got a great future. I honestly believe that. And it's because of the factors I think I just mentioned. So, but if you could join a group or a hospital system or a health system, that's where, or an orthopedic group, I think that's where you want to be.
Well, this was awesome. Are we going to see you at the National? Are you going to be heading to DC later this summer? Or are you going to be hitting the links and or pickleball court during
Well,
that?
I'm not a pickleball player. That's number one. Number two is no, to be quite honest, I never attend the national meeting. To be honest with you, I think it's worthless, and I never attend, and I have no intention of ever attending. So
you like the smaller, more intimate meetings, perhaps?
Well, my days of being a leader that way are over. I mean, I give credit to organizations like ACFS, for example. Look at the lecturers that they have now. They've opened it up, and you've got a lot of younger doctors lecturing now, names you don't even recognize. You will in the future, I'm sure, but they've gotten away from same old. APMA doesn't do that. It's the same old guys and ladies giving the same old lectures over and over again. We've got to open it up to these young minds, encourage them to take leadership, encourage them to move things forward. And I have a lot of admiration for ACFAS because they have opened it up to younger people. I look at all their programs and I go, gee, I wonder who this person is or that person is. And I go online and I look them up and I see the wonderful training these kids are getting now. And they should be doing that. APMA has not done that. That's my honest opinion. And I feel badly saying that, but it's the truth. I don't want to hear old guys like me giving the same old lecture over and over again. Well, listen, as always, I appreciate your no holds barred approach, and you're shooting from the hip as you see it. And that's the way I think it should be. Thank you so much for doing the podcast with me, and I wish you continued success, and look forward to running into you up the road. I'll see you somewhere, Ben. Okay. Bye now. All right, thank you.